on the Department of Defense's efforts to address and prevent service member suicide. Let me start by welcoming Senator Tillis, our ranking member of the subcommittee. I also want to recognize Senator Tuberville for joining us on the onset. On many issues that have come before this subcommittee, Senator Tillis and I have worked well together, and I know the issue of today's hearing is also one that has been top of his mind and a priority of his. I look forward to working with Senator Tillis to investigate and address suicide prevention across the department and find bipartisan solutions to help support our service members and their families. Suicide in the military is an epidemic and one we cannot ignore. Last September, in my home state of New York, 3 service members based at Fort Drum died by suicide in 3 days. What that demonstrated is that no community is immune to the crisis. After meeting with General Beagle of the 10th Mountain Division last month, I was pleased to learn that the programs that their leadership is putting in place to prevent suicide, from providing additional resources to training individuals at all levels to identify those at risk, and taking a holistic approach to provide supports to service members so they feel better equipped to handle a range of challenges that they may face. I have also believed mental health among our service members is a readiness issue, and in order to foster resilience and build troop fitness, our service members need the tools to feel less overwhelmed and stressed, in addition to having access to mental health services as needed. My goal in holding this hearing today is to better understand what is being done by DOD to prevent suicides in our military, and to learn more about what can be done to further eliminate barriers that stand between our service members and access to mental health. We have to end the stigma that is too often associated with requests for help. In the last annual report on suicide, using data from 2020, the Department of Defense noted that suicide rates for the active component increased from 2015 to 2020. During this time, the department made substantial investments to prevent suicide among the ranks, including training programs for service members, investment in communications and outreach platforms, and increased access to behavioral health screening and resources. Yet suicide rates continue to increase. While I am cautiously optimistic about the 2021 data, which was just released last week and indicated a 10% drop in service member suicide, 518 service member deaths are still far too high, and the department still has much work to do to prevent these tragic losses. I'm looking forward to hearing from today's witnesses on this topic. We will have 2 panels. The first consists of DOD witnesses who will testify about the department's suicide prevention programs and its related behavioral health interventions, and representatives from the Inspector General's office and the Government Accountability Office to help us understand the efficacy of these programs and any recommendations they have for improvement. Our second panel will include a military family member who has personally impacted by suicide, and experts outside of the department who have experience in research and outreach in suicide prevention. Our first panel witnesses include Dr. Karin Orvis, Director, Defense Suicide Prevention Office, Department of Defense, Dr. Richard Mooney, Acting Director, Deputy Assistant Secretary of Defense for Health Services Policy and Oversight, DOD, Mr. Mark J. Rourke, Deputy Inspector General, Evaluations Component, Department of Defense, Ms. Brenda Farrell, Director, Defense Capabilities and Management, Government Accountability Office. I'll also introduce the second panel after we receive the testimony of the first panel. Again, I welcome our witnesses today. Thank you for appearing, and thank you for your testimony. Senator Tillis.
Thank you, Senator Gillibrand, for this hearing on military suicide prevention and mental health care. It will come as no surprise that we have a mental health care crisis in this nation. The demand for mental health services far exceeds the supply of mental health care providers. The Health Resources and Services Administration estimates by 2025 we'll have a shortage of over 250,000 mental health professionals, psychiatrists, mental health and substance use disorder specialists, and clinical and school psychologists. We don't train enough of them. Their pay is low compared to other healthcare professionals with similar education and experience, and we place more administrative demands on them, and the pace of their work often burns them out. While this subcommittee can't fix these problems for the nation, we can look to improve access to mental health in a military health system. I look forward to hearing from the witnesses on the first panel about the mental health staffing challenges in DOD, and to better understand what this subcommittee may do to help the department recruit and retain more military and civilian mental health providers. I also want to know the challenges that patients face when they are referred to care for the TRICARE network. And finally, tell us how DOD will expand the use of telebehavioral health, especially in remote locations where in-person services aren't available. Now, turning to the issue of military suicides. Every suicide is a tragedy that could have been prevented with early intervention. From DOD's data, we know that most suicides occur in young, enlisted males who may have experienced financial problems, failed personal relationships, or legal problems. Leadership up and down the chain of command, from the general officer down to the most junior NCO, must do a better job of developing service members' connectedness to their military unit, to their families, and their supporting community. Military leaders need to know how to identify service members at higher risk of self-harm. They must eliminate any remaining stigma associated with seeking mental health care, and they must prioritize service member getting help over mission requirements. I'm encouraged by Secretary Austin's recent memo to stand up a Suicide Prevention Response Review Committee, a requirement under Section 738 of the NDAA for fiscal year 22. I thank him for including Camp Lejeune and the North Carolina National Guard as two of the locations that the committee will review. I want to hear more about that committee and the work that's going to be done. Finally, I want to thank the witnesses on Panel 2. I want to thank all the witnesses for being here, but especially the witnesses on Panel 2 who are from Durham, North Carolina. Dr. Doraiswamy, who's back in the back corner to my right, from Duke University of Medicine, School of Medicine, and Mr. Ford from a terrific nonprofit organization called Stop Soldier Suicide. I hope the witnesses on Panel 2 can describe some of the innovative best practices in suicide prevention and help us understand how technology can be applied to prevent suicides. Again, Senator Gillibrand, thank you for holding this important hearing. I look forward to hearing everyone's testimony.
Thank you. We'd now like to hear from our witnesses. Dr. Orvis, we're prepared to hear your opening statement first.
Thank you. Madam Chair Gillibrand, Ranking Member Tillis, and distinguished members of the subcommittee, thank you for the opportunity to appear before you today. Let me start directly first. I'm deeply disheartened by the rates of suicide in our military. Every suicide is heartbreaking, resulting in horrifying pain of losing a loved one. This drives us every day to find answers, to ensure those who need help ask for and receive that help, and to be certain that not another son or daughter, brother or sister, or mother or father must also live with the searing pain and emptiness that never goes away after losing a loved one to suicide. This is a shared challenge. Nationwide suicide rates are alarming, and we continue to observe heightened risk for our young and enlisted service members. My office, the Defense Suicide Prevention Office, works to enhance holistic, data-driven suicide prevention through non-clinical policy oversight and engagement across populations in our armed forces. DoD Health Affairs joins me today to discuss their work with individual service members in healthcare settings, including clinical suicide prevention efforts and mental health delivery. Together, we're committed to addressing suicide comprehensively through a public health approach. We also leverage best practices from the broader scientific community, including the Centers for Disease Control and Prevention, or CDC. We work closely with the military services. Together, we've developed a program evaluation framework that aligns with the CDC's 7 evidence-informed strategies for suicide prevention to track progress and holistically measure our program effectiveness. We're also taking action to ensure all service-level individual programs are assessed for effectiveness per GAO's recommendation. Last month, the Secretary of Defense directed the creation of the Suicide Prevention and Response Independent Review Committee to conduct a comprehensive review of the department's efforts to prevent suicide that will inform long-term progress. He selected 9 locations to increase our understanding of the needs of service members across various geographies, including remote and OCONUS areas such as Alaska, as well as across both our active and reserve components. Likewise, we welcome forthcoming insights from GAO regarding our remote and Oconus communities. DoD has many ongoing and new efforts underway, including new research and several evidence-informed pilots related to help-seeking, problem-solving, and means safety. For example, we developed and piloted an interactive training to address service members' most common help-seeking concerns and to encourage help-seeking early on using resources before challenges become overwhelming. We're currently expanding this training to ensure it meets the needs of our remote and Oconus service members. Our data tells us that suicide is often a sudden and impulsive act, and that adding time and distance between an individual with suicide risk and a lethal means can be life-saving. Our suite of evidence-informed tools reinforces the positive impact of safely storing firearms and medications. A concerted DoD-wide implementation of these tools supplements our other efforts, such as training non-medical providers about suicide risk and safe storage of lethal means. In closing, I thank you for your unwavering dedication and support of the men, women, and their families who defend our great nation. Efforts and insights from the SASC Personnel Subcommittee, GAO, and the DoDIG have been critical to our work. I fully recognize we have more work to do, and I look forward to our discussion today.
Thank you, Dr. Orvis. Now I'd like to invite Dr. Mooney to give his opening statement.
Chairwoman Gillibrand, Ranking Member Tillis, members of the committee, good morning, and thank you for the opportunity to testify before you today. First, I'd like to thank our GAO and DoDIG colleagues for their ongoing work that fuels improvements across the department and larger government. The bottom line is that every suicide is a tragedy that weighs heavily on the Department of Defense and the broader military community. Suicide rates among our service members and our military families are too high. Because DoD is responsible for protecting our service members, just as they're responsible for defending our country, we must do everything possible to prevent suicide in our military community. We're doing this by encouraging help-seeking behaviors, eliminating stigma, and enabling access to mental health clinical services. We're promoting the utilization of mental health services even as we have a nationwide shortage of mental health providers, which creates challenges in ensuring access to care. The Defense Health Agency is working to develop a staffing model to address these challenges in order to provide timely mental health care with the goal of treating 100% of active duty service members in the direct care system. To mitigate challenges in supply, we continue to rely on the civilian network, aiming to provide care within our access to care standards. DoD also works to routinely screen service members for mental health concerns throughout their service, from the first visit for new patients, annually during the periodic health assessment, before and after deployments, and prior to separation from military services. In terms of treatment, the DoD and VA co-develop clinical practice guidelines to address suicide and conditions that increase the risk of suicide, like PTSD, traumatic brain injury, depression, and substance use disorders. We know from research that suicide results from a complex interaction of many factors, so while there's no single solution in suicide prevention, the clinical practice guidelines reduce unwanted variance in prevention and treatment of those contemplating suicide. While we remain vigilant in the effort to combat stigma, data suggests we are trending in the right direction. This is suggested by increasing demand for mental health services, which indicates that service members feel less reluctant to get the help they need and deserve. The American Psychological Association reports that Generation Z, which represents our youngest and future military force, views mental health differently from previous generations. Generation Z is more open about their mental health, more likely to report poor mental health, and more likely to seek mental health care. We must continue our clinical and non-clinical stigma reduction efforts to ensure this cultural shift continues and our service members are at ease in seeking mental health care. We remain grateful for this committee's support for the Department's suicide prevention efforts and the opportunity to discuss the Department's clinically related suicide prevention efforts today. We recognize we have more work to do and much more progress to make to prevent this devastating loss of life. Our efforts will continue to address the many aspects of life that impact suicide, and we're committing to addressing suicide through a comprehensive public health approach. Thank you.
Thank you. I'd now like to invite Mr. Rourke for your opening statement.
Good morning, Chairwoman Gillibrand, Ranking Member Tillis, and distinguished members of the subcommittee. Today, I will discuss 3 reports: suicide prevention for transitioning service members, access to mental health care, and the impact of the COVID-19 pandemic on military treatment facilities. First, I will discuss our November 2021 report on suicide prevention for transitioning service members. The objective of this evaluation was to determine whether DoD provided suicide prevention resources for transitioning service members as required by Executive Order 13822. Our report found that the DoD did not consistently screen for suicide risk or arrange for uninterrupted mental health care for transitioning service members as required by the Executive Order and DoD policy. Specifically, the DoD did not establish and implement oversight of mental health assessments and suicide risk screening processes for transitioning service members. Additionally, DoD Instruction 6490.10 lacks a clear definition of a warm handoff, provider training tools, standardized documentation methods, and oversight procedures to ensure compliance. These challenges occurred because the Defense Health Agency and the military services did not include a mental health assessment and suicide risk screening as part of the separation history physical exam, which is the medical exam required to be administered to transitioning service members. Additionally, the DoD and the military services relied on expired policy to govern suicide risk screening and referral processes. The inability to identify suicide risk and arrange for uninterrupted mental health care in transitioning service members may result in a lack of mental health care, thus jeopardizing patient safety. We made 5 recommendations to address the deficiencies we identified. We recommended that the DoD establish consistent policies and procedures to manage suicide risk screening and referral as part of the medical process for transitioning service members. We recommended that the DHA identify the causes for breaks in arranging for continuous mental health care for service members who are transitioning from the MHS to the VHA. We also recommended that the DoD create and implement solutions to increase the number of service members who have continuous care arranged between the MHS and the VHA at the time of transition. Second, I will discuss our August 2020 report on access to mental health care. We determined that the DoD did not consistently meet outpatient mental health access to care standards for active duty service members and their families. Specifically, from December 2018 to June 2019, we found that 7 of the 13 MTFs we visited in the direct care system and their supporting TRICARE network in the purchase care system did not meet the specialty mental health access to care standard each month. And an average of 53% of all active duty service members and their families identified as needing mental health care and referred to the purchase care system did not receive care. These challenges occurred because the DHA lacked an MHS-wide model to identify appropriate levels of staffing in direct care and purchase care, and published inconsistent policies on access to mental health care. In addition, the DHA did not have visibility over patients who attempted but were unable to obtain mental health appointments in the purchase care system and measured the 28-day specialty access to care standard differently between the direct and purchase care systems. As a result, thousands of active duty service members and their families may have experienced delays in obtaining mental health care. We made 14 recommendations to the Assistant Secretary of Defense for Health Affairs and to the DHA to improve access to mental health care in the DoD. Finally, for our third report, which we issued yesterday on April 5th, we issued this report discussing the challenges that are facing MTFs at this stage in the COVID-19 pandemic. Although this report focused on a wide variety of challenges that the MTFs are facing, we asked senior leadership at 30 MTFs what was the most serious concern that might be encountered in the future by medical personnel working at your MTF during the COVID-19 pandemic. Officials from 25 of the 30 MTFs discussed burnout of medical personnel as a serious challenge. However, officials from 11 of the 30 MTFs stated that staff burnout and fatigue was the most serious concern that might be encountered in the future. MTF officials told us that burnout has caused some staff to quit, further exacerbating staff shortages. In addition, MTF officials stated that burnout has adversely affected staff members' psychological health and caused them to use emergency mental health services for their own behavioral health challenges. This concludes my statement, and I'd be happy to answer any questions you may have.
I'd like to invite Ms. Farrell to give her opening remarks.
Chairwoman Gillibrand, Ranking Member Tillis, and members of the subcommittee, thank you for the opportunity to be here today to discuss our most recent work related to suicide incidents at remote installations outside the contiguous United States, OCONUS. Suicide deaths and attempts within the military are devastating events for families. They can also harm unit morale, esprit de corps, and readiness, and increase the risk for suicide among affected service members and their families. Remote OCONUS installations may pose challenges that increase suicide risk. GAO's prior work found that DOD's efforts to prevent and respond to suicide deaths and attempts have encountered challenges. Our prior work addressed DOD's mental stigma reduction efforts, effectiveness of non-clinical prevention methods, inconsistent use of suicide-related terms. The NDAA for FY 2021 included a provision for us to review suicide prevention efforts at remote OCONUS installations. My statement today is based on our work being conducted in response to that statutory mandate. Now I'll briefly highlight 4 areas in my written statement. First, my statement addresses what is known about the incidence of suicide and related risk factors among service members at remote OCONUS installations. Our preliminary analysis suggested that remote OCONUS installations accounted for a slightly higher proportion for suicide attempts, but a lower proportion of suicide deaths relative to the proportion of service members assigned to these locations during 2016 through 2020. DOD officials told us that the extent of suicide deaths at OCONUS installations may be lower because service members assigned to installations outside the U.S. have limited access to non-military issued firearms. We found that non-military issued firearms were involved in over half of reported suicide deaths among members assigned to CONUS installations and were involved in slightly over a quarter or fewer among members assigned to OCONUS installations. Separately, DOD service and installation officials we interviewed identified risk factors for suicide and related challenges that may be more pronounced at remote OCONUS installations, such as less access to mental health services, increased social isolation, and extreme weather conditions. DOD does not have a process to assess suicide risk at these installations. Establishing such a process could enhance related suicide prevention efforts. Second, we found that gaps exist in implementing some prevention policies, programs, and activities for those assigned to remote OCONUS installations. For example, 3 services have not ensured implementation of some prevention activities, such as establishing required prevention teams at installations. These services do not have mechanisms to help ensure implementation. By establishing oversight mechanisms, these services may have greater assurance that such activities are implemented across all installations, including OCONUS installations. Third, we also found that DOD has experienced staffing shortages, as noted earlier today, for behavioral health personnel, in part because it has not developed a strategy to address hiring challenges. By developing such a strategy, DOD may be able to enhance the provision of behavioral health care to service members and their dependents. Last, DOD has established some suicide response guidance and training for key personnel, but gaps exist. For example, DOD has not established statutorily required training for commanders on responding to suicide deaths and attempts. By establishing such training for commanders, DOD can better ensure that commanders are prepared to provide support to suicide attempt survivors and the bereaved. In summary, on March 1st, 2022, we provided DOD with a copy of our draft report along with the recommendations. We will complete the work as soon as we receive DOD's review and comment of that draft report. Madam Chairwoman, I'm pleased to take questions when you're ready.
Thank you very much for your testimonies. Very challenging and difficult issues, and I appreciate the expertise that you've developed. I want to first talk about the lack of access to care. Dr. Mooney, in 2020, The DOD Inspector General found that as a result of delays in required mental health care access for active duty service members and their families, numerous members were not able to see the right provider at the right time, obtain mental health care, or receive timely follow-up treatment. What steps is the department taking to address these barriers accessing needed care? And second, related, how does the DOD track the time between the patient request or referral for mental health care to the time of the mental health assessment? Have you seen long waits, and what steps are you taking to improve that?
Yes, ma'am. Thank you. So to your first question on access to care and how we're approaching that, we have a nationwide shortage of behavioral health providers, as has been mentioned in this hearing already. And so to that end, we have worked to build a staffing model that will match supply with demand by provider type. And the goal will be 100% of active duty service members in the direct care system being seen with on base. And that staffing model we anticipate to pilot this fall, and it will impact 100,000 beneficiaries. With regard to making sure our provider type is matched with the patient, active review and management of appointment schedules 24 to 72 hours before each appointment to ensure the right patient with the right appointment and the right provider. To increase access to care, we're also adding extenders, and we're also PAs, nurse practitioners, licensed mental health counselors, also entertaining adding new provider types, credentialing new provider types to include licensed professional counselors and licensed family and marriage therapists. Additionally, to increase access to care, we're doing a massive expansion of telehealth. That's one of the top priorities for the Defense Health Agency. Our SMEs suggest that between 50 to 75% of behavioral health conditions can be treated virtually, depending on acuity. That would free up time to manage more severe cases in person. This expansion will add 63,500 virtual appointments by the fall of 2022. Those are central appointments that can be used worldwide. So with regard to access and how that's measured, so for a given clinic, your access to care is basically in the system. There is a appointment made date and an appointment seen date, and that across the clinic for that particular month or period of time you're looking at, that average for all patients seen there becomes your access to care standard, or your access to care. The standard for access to care for a routine appointment in behavioral health is 28 days. That's that means routine. If you have an acute issue, you can go and are seen earlier. Usually acutes are within 24 hours. They can be seen in the clinics or in the hospital, in the emergency department. So we want to make sure we have that distinction between a 24-hour acute type visit versus a routine visit.
It still seems very long. You mentioned in the testimony, several of you, about staff shortages. So Dr. Orvis, you can start. There's been a great deal of reporting lately on staff shortages of mental health professionals, specifically on and around military bases. What are the biggest challenges military installations are reporting in ensuring access to adequate treatment in a timely manner? And what steps is DOD taking to increase the number of mental health professionals available to provide supports to service members and their family members?
Certainly. Well, I would want to defer to my colleague, Dr. Mooney, in terms of mental health professionals, because that falls in the purview of health affairs. But what I can offer in terms of non-medical providers, we have other help-seeking resources for our service members. And so we're really looking not only in terms of behavioral health professionals, but encouraging our service members and our family members to seek out help when they need it from a resource that is right for them. It may be a behavioral health provider, it may be a chaplain, it may be a military one-source counselor or a military family life counselor, or even the Veterans and Military Crisis Line. And I'll just give one example within that, or an external provider as well. Given Hour is just one example, but we have many wonderful partners in the community that would be potentially a great resource as well. Within the military community and non-medical providers, military family life counselors are available on installations, and they're also available for surges. So if there are particular locations that need additional support, maybe after a loss of a service member due to a suicide, additional personnel can also be brought into that unit or to that installation to provide further support. And I'll defer to Dr. Mooney for mental health.
Yes, ma'am. Thank you. With regard to our ability to recruit and retain, there are pay flexibilities in the 2021 NDAA that have increased special and incentive pays for our uniform service members, and we're working, DHA is working with the military departments to understand how that's impacting the ability to retain that talent, and will adjust as indicated. With regard to being able to hire civilian providers, behavioral health providers, there are some Title V pay caps that if we could work with, that may be a way to be more competitive with some of the civilian counterparts. Some of these areas where you have a significant shortage, you have a difficult time competing with the civilian sector's ability to pay salaries to behavioral health providers, civilian behavioral health providers.
Thank you, Senator Gillibrand. Again, thank you all for being here. Dr. Mooney, I wanted to, I know, and Mr. Rourke, you may want to contribute to this, but I know that with our response to the pandemic, we saw medical professionals deployed out of the DOD into the civilian sector to help marshal resources for the pandemic. To what extent did that affect the subject, the provider population within the DOD?
So with the provider teams that were deployed, that segment of our population that was deployed were more acute care, your pulmonary, critical care specialty, that sort of group. So with regard to behavioral health, I'm not sure there was as much of an impact there on staffing. But I think that we're all concerned. I've read the recent IG report on the impact of the pandemic on the staff.
Certainly increased caseload.
Yes, sir. Yes, sir. And also it led to a referral to our purchase care network, because when, just as in wartime, when your staff deploys, similarly here, when the staff deployed to support our civilian hospitals, the TRICARE network was our relief valve. Over.
That I wanted to talk about particularly when people experience profound behavioral health challenges, maybe for the first time in their life, and you're not able to provide care within the DOD, and you provide a referral. I worry that can, without a warm handoff, I want to talk a little bit about the warm handoff to TRICARE, but give me a sense of what we can do better to make sure that when someone gets a referral, they actually get the care. Because in my research on this, if you don't have family members or caregivers or other people engaged in that, or the DOD engaged in that, and to know that after a referral is made, that they've actually sought the care, how are we doing a better job to make sure that that referral has resulted in a positive outcome in terms of getting the care that they've been referred for?
Sure. No, that's a great question. I think that stepping back, with regard to mental health assessments and the warm handoff, we are working a directive-type memorandum that will implement a one-separation health assessment between the DOD and VA. With that directive-type memorandum, which will be placed in policy, the 6490.10 that he mentioned, this will this will ensure the warm handoff. This will connect through the in-transition program to the VA. It also ensure a mental health screen occurs, and there are flow diagrams in this policy that give instructions to the providers on what to do, if-then statements, what to do with the results you have, and how you ensure proper care and handoff in the transition process.
Mr. Rourke, you have anything to add to that?
Yes, as Dr. Mooney said, there is a role for the service members to play in making sure that their care continues as they transition. However, we have tried to recommend solutions to the department of ways that we could make that as user-friendly as possible. And so we have been working with Dr. Mooney and his staff to determine how quickly the implementations that we recommended in our report are being implemented, and I think that the steps that he discussed are the major improvements that we're following in terms of things that could be done better in the future.
Yeah, I agree that there is a role the service member, excuse me, has to play, but you also have to understand the conditions that they're operating in, and if we don't have a greater touch on that, it's my understanding, at least in the literature that I've read, that when you first experience it, you may not be behaving rationally to begin with, and now you're asking them to take an added step to get care, which can by itself be traumatizing. So it's one thing to expect them, excuse me, to get that care. It's another thing to see whether or not they'll follow through with their responsibilities. And I do have some questions for a second round, but Madam Chair, I'll defer for now.
Senator Tuberville.
Thank you very much. Thank you for being here today on such an important and progressing problem that we have. I'm on the VA committee, and I've been pushing some non-traditional types of therapy. In my former life of being a football coach, I had a lot of brain injuries, and we were fairly successful using hyperbaric therapy with a lot of our football players. I've seen enough of physical drugs in my lifetime to try to cure a lot of these problems that we're having. Sometimes it works. More than not, it doesn't. Dr. Mooney, what do you think about non-traditional therapies such as hyperbaric therapy with our DOD, through the DOD?
Sure. I think that, anything that we do system-wide, we need to study and evaluate and understand the impact. And I've had several cases myself where from traumatic brain injury, hyperbaric seemed to make a difference. But I think more study needs to take place before that can be endorsed more broadly. But no, I'm in favor of any of the innovative approaches. I mean, it's a matter of understanding if there are other unintended outcomes from those approaches. So it's the systematic evaluation and then the rollout.
Anybody else have any thoughts about non-traditional therapy? Anybody? Do you collaborate with the VA on things like this?
Yes, sir. We have an entire organization, the Health Executive Committee, that works with the VA. I'm the business line lead for 3 of the business lines, so there's a lot of work underway collaboratively.
Mm-hmm. Thank you. Dr. Orvis, University of Alabama is currently conducting a study titled Operation Deep Dive to review state death data, cross-reference it against the DOD military service and the VA. I'd like to thank you for your involvement in this study and for the wisdom that you share with the students of Alabama. Thank you very much for that. Preliminary data from Operation Deep Dive is showing that members of the National Guard have 10% higher suicide rate and reservists 45% higher suicide rate than their active duty counterparts. What insight can you share with us on these findings of Operation Deep Dive?
Appreciate the question and appreciate the work that's going on. A really important study, and this and other research, of course, that goes on helps us, right? It helps us uncover gaps that we may not be aware of, or new pieces of information that add to our puzzle and help us identify what do we need to do differently to make a difference. So very much appreciate the work that's going on. You know, when we're looking at our reserve component members, our National Guard members and reserve members, we really have been looking and to understand why there may be differences and how it may be different compared to active component service members. And certainly, even in terms of thinking about the timing or the manner of death for our active component service members, they are on active duty at the time. For our National Guard and Reserve members, the majority of individuals are dying by suicide when they are on non-active duty status, about 75%, both in the Reserve and the National Guard, and we see that pretty consistently. So we know it's perhaps even more complicated for our National Guard and Reserve members, handling two lives that they're traversing, their military life and their civilian life, and their military role and their civilian job. But we also know that there are commonalities across our service members and across individuals throughout the U.S. in terms of causes of suicide. We know financial challenges, when coupled with other things, can influence risk for suicide. Do we have a protective environment for the individual? So when we're really focused in the DoD, particularly right now, on safe storage of lethal means, firearms, medications, other lethal means, and data from our broader U.S. population, so of our U.S. civilians, does indicate that there are certain regions within the U.S. that have higher access to personal firearms, other lethal means, and that may also be a contributing factor.
It's got to be a pretty good shock to be a National Guardist or reservist. One day you got a job, the next day you're, in harm's way. And I can imagine on their family too. So thank you for that. I got a couple more questions. I'll wait on the second round. Go ahead.
I wanted to talk a little bit about reducing stigma. You mentioned it in some of your opening statements. I was proud to support the Brandon Act, which some provisions passed in our last NDAA to reduce stigma around reporting by allowing their service members to seek help confidentially and, if needed, outside the chain of command. Dr. Orvis and Dr. Mooney, can you talk about DoD's planned implementation of that policy and what, if any, impact you have seen or expect to see in ensuring needed treatment is sought out? And Ms. Farrell, in the 2016 GAO report, the additional actions were needed to enhance DoD's efforts to address mental health care stigma. Has anything been done to destigmatize mental health care treatment since that time, and what additional steps would you recommend?
Yes, ma'am. So the Brandon Act, Section 704 of NDAA 2022, will make a big difference, I believe, in reducing stigma and enabling our service members to feel comfortable in discussing and triggering a referral with their commander to get medical care. We are in the midst of socializing the directive-type memorandum that will launch this program, and we anticipate entering that directive-type memorandum into coordination in May of 2022. And the current policies, the current medical policies covering referrals include DODI 6490.08, command notification requirements to dispel stigma and providing mental health care to service members, and 6490.04, mental health evaluations of members in military operations.
Yes, we're in support of Health Affairs in terms of their implementation of this important new provision. As I mentioned before, we're really looking to identify how can we encourage in any way help seeking and to reduce the stigma that we know is associated with seeking help, whether it's mental health care or other types of help seeking, not only in the military but also more broadly. I would just offer as a few other things that we're doing, which is outside of this provision. We're from the highest levels of our leadership, from Secretary Austin to Deputy Hicks, we're really trying to look at different ways in which to help to reduce the stigma among our service members and families. You had referenced outreach and efforts that we're doing and ramping those up, and most certainly we are. We also recently, Deputy Hicks directed a stand-up of a new interdisciplinary working group that is a intersection of suicide, mental health, and the intelligence and security expertise within the department, looking at, we know that our service members have concerns about career impacts associated with help seeking, and we know that this is very complex, but there is data that suggests that, at least in terms of security clearances, for instance, that really is a very small, less than 1% likelihood that someone seeking mental health treatment would have an impact on their security clearance. But yet that kind of misconception exists. So how do we get after that? And how do we understand the various assignments or deployment requirements that might be associated with mental health and concerns about not seeking help because of impacts on assignments that an individual might have. So there is a new working group that was just recently stood up that is really looking at this, making recommendations of what do we need to do in terms of changing policy and or changing training for commanders, for the workforce, for our service members and family members to get after that one piece of stigma, of the larger stigma puzzle.
I think not. Here we go. You can. Thank you for mentioning the 2016 GAO report. I'm happy to say that all of the 7 recommendations in that report have been implemented as of last year. It's hard to believe, but in 2016, there was not a consistent definition of what are these barriers that prevent people from seeking health care that is generally referred to as stigma. So that was a huge step for DOD to look at those barriers and define them. They've done other actions such as destigmatizing policies that one was mentioned about security clearances, that the policies could have wording that could also present barriers. So they've revisited those policies and taken action. They've established a coordinating entity to collaborate with others and oversee the destigmatizing efforts. They're now in a good place in terms of establishing goals and measures, which we know they have done to actually measure the effect of their efforts to address stigma. So that will be the next focus, to look at what they're doing and see what's working and what's not working and refocus if necessary.
Thank you. Senator Tillis.
Thank you, Senator Gillibrand. Dr. Orvis, the Suicide Prevention and Response Independent Review Committee is going to focus on non-military installations as a part of the process. Can you give me an idea of how they went about choosing the non-military installations that will be a part of the review?
Sure, absolutely. The 9 locations were selected using a data-driven methodology, which I can speak a little bit more. And we also ensured that we coordinated with the military departments to gather their insights as well. We wanted to make sure that, and per the Secretary's direction, that we were addressing various needs of our service members. So looking at various, excuse me, geographies to include remote and OCONUS areas. Excuse me one second. In terms of the data-driven methodology, we looked at both suicide data as well as command climate data to identify installations that were higher in terms of risk factors for suicide and lower in terms of protective factors. And so that drove the recommendations for those nine installations, as well as we wanted to ensure that we were representing all of the military departments and representing both active and reserve components of our service members.
That actually, your comment about command climate, when was the last time, if ever, that we've done a command climate survey on issues related to eliminating the stigma, providing more access to care? Has that ever occurred? We just what made me think about it is we just recently were briefed on military sexual assault command climate survey. There were a lot of action items coming out of that, and it would just seem to me that this would be a natural part of building on the recommendations from the GAO report. And I was just curious, has that been done before?
I would have to take for the record when that, if that occurred and when those particular items may have been included in a systematic way. Within the current redesigned Command Climate Survey, it is looking at various risk and protective factors that contribute to healthy and unhealthy climates. And then there's also an opportunity within the survey to be able to have commanders ask specific questions that they're interested in being able to gather more information on. So that may have occurred in individual surveys, for particular commanders. What I would also offer is we have the Status of Forces survey. That's an annual survey. And consistent items within that Status of Forces each year is asking about barriers to care, stigma. So we do have robust data from our service members in understanding their perceptions on what is holding them back from seeking care. If they would seek care, who would they be willing to, which source would they be willing to seek out care from?
Well, thank you. I think it'd be helpful. I think one of the findings that I took away in the review for military sexual assault is it tends to have more to do with the climate created by a current command rather than a continuity of culture. And we've got to get that cultural foundation in place. Dr. Mooney and Mr. Rourke, before I go to Dr. Mooney, Mr. Rourke, you had talked about some of the challenges have to do with transition and post-transition stickiness. I feel like this is an area where we have so much work to do in our transition assistance program, and making sure that's not just being well-informed when someone's transitioning, but it's very similar to what I was talking about with the warm handoff for referrals. When we know that there is a serious or potentially serious challenge out there, we have to do a better job on an interagency basis of tracking and determining whether or not they're actually getting care that we suspect that they need at the point of transition. Did your report, point out any recommendations or actions that the department should take?
Yes, and an important point about our suicide prevention report was that we developed the concept for that evaluation in concert with the Veterans Affairs OIG. And so working collaboratively, we determined that transition period, 1 year prior to transition and then 1 year post-transition is such a critical time for suicide and mental health, continuity of care and suicide prevention. So that was kind of the overall umbrella under which this work was done by our agency. 2 points that we mentioned in our report, which I think are really important, are the mental health screening that was required by the executive order. In 2020, only 34% of transitioning service members received that. And then secondarily, on the separation health physical exam, only about 70% in 2020 completed that exam. And so in terms of items that would put the VA in the best possible position, if the DOD can...
They don't know what they don't know.
Exactly. If the DOD can put both the service member and the VA in kind of the best possible situation as they leave the department, then that's the goal. And we made recommendations to the department, and that's what Dr. Mooney was discussing earlier in terms of some of the changes that they have in the works to try to improve that.
Yes, sir. The one separation health assessment between the DOD VA has a lot of protections. It ensures understanding of the requirement for the behavioral health evaluation. It also has a linkage to the in-transition program so that the warm handoff can occur to ensure care. One piece, though, is that not every service member who retires or separates seeks care at the VA. They can go off to other providers. So that's another area for concern and for work.
Thank you.
I'm just curious, and there might not have been enough time, but has there been an uptick in suicides since the fall of Afghanistan last August? Does anybody have any data on that?
Thus far, our data does just not support that, but we're looking to see what may occur, and we're working closely with the Department of Veterans Affairs as well, as it may be impacting our veterans.
Okay, thank you. You know, our military is a tool of national power, and we as lawmakers, you know, sometimes have the ability to send people in harm's way. You know, what resources does the DOD, Dr. Mooney, make known and available to the service members, to their families and their friends, and, you know, financial, you know, marriage counseling? Is there anything that we offer to our men and women? Or anybody can answer this. I'm just looking for answers.
Sure. Most of that is probably in Karen's lane, but I can tell you as a person who has deployed in the past, there are deployment lines, there are you know, chaplains, there are other folks there that coordinate, you know, and provide resources for the service member and for the family.
Okay, thank you. Anybody else?
Sure, I'll add to that as well. Absolutely, both in terms of our service members and family members, we have a host of resources in terms of helping with kind of everyday life and life challenges. So have strong financial supports in terms of not only financial education across the military life cycle, but also free resources available both on installation and virtually online for assisting with financial health and challenges, right? Also have, I had mentioned earlier, Military One Source and the Military Family Life Counselors. They're really designed to be able to help with those everyday life challenges as well. Could be finances, could be relationship challenges, whether that's in significant partner relationships, parenting challenges. They help support with relocation or with deployment challenges, both and reintegration challenges coming back, and offer free resources to our service members there. And then, of course, there are community resources available as well that we have partnerships with, just as a few examples.
Ms. Farrell, you have anything to add to that?
I do, thank you. There's no doubt that DOD has a management framework in place that's very comprehensive with a governance structure, part of the governance structure sitting at this table, as well as collecting the relevant data and assessing it and putting forth strategies. But our work looking at remote OCONUS locations found that sometimes the implementation was not what it should be, and there were gaps in the policies and the programs and the activities at those remote OCONUS locations. I don't know about all the CONUS locations, but you know, it comes down to actually having the boots on the ground implementing those activities that are prevention activities or specific key personnel that should be assigned at those locations that coordinate the clinical and the non-clinical, for example. So that is an area that we have made recommendations for DOD to have oversight mechanisms in place, among other things.
Thank you. Thank you, Mr. Chair.
Yes. So in our suicide prevention report, we did identify and review some of the programs that are available to some individuals who are transitioning, such as members who are have a disability and are going through the board process to be separated from the military. Also, the In Transition program for folks that have prior mental health care in the last year. However, although there were good things occurring in those particular programs, the overall population of active duty service members transitioning was at least 160,000 per year. So, you know, although there are some programs that are effective in certain populations, you know, it's important to think about the larger population as well, and to make sure that some of those lessons learned can be spread to the larger population.
Any other recommendations that the panel would like to give before we close out the panel? On any questions that have been asked so far?
Madam Chair, before we close, I mean, there's no question in my mind that the DOD would like to end suicide. We have challenges. The OIG has pointed out some. The GAO has made recommendations. What would be very helpful for this committee is the extent to which, as we move into the NDA, any additional authorities or focus that we should place on this to give you more enablers to do the job I know you want to do. And then I do have several questions for the record we'd appreciate your attention to.
Yeah. And please be specific in your recommendations. I mean, we've heard a lot of challenges, not enough staff where they're needed, very long wait times. Having a normal wait time of 28 days is fine if you're not in trauma or in distress, but if these individuals can't self-identify that, then it's a failure. They need that intervention. So please take the time to make specific recommendations for money that you need, personnel that you need, support for programs that already exist, additional research, whatever it is. I'd like a direct recommendation of things you'd like in this year's NDAA to address the problems that we still have. Given all the good work we've already done, given all the things we've put in place, we need direct recommendations and requests to guide us in writing this personnel markup. So thank you. Any other questions from the senators? Thank you very much.